Glofitamab is a CD20-CD3 bispecific antibody which targets CD20 on the surface of B lymphocytes and CD3 on the surface of T lymphocytes. And it works by attracting T lymphocytes and binding them to B-cell lymphoma cells. That leads to T-cell activation and tumor cell death, as well as a secondary T-cell response. In this phase 2 study, we evaluated the phase 2 go-forward dose that we'd established in the phase 1 portion of the study. We give Gazyva or obinutuzumab as a single dose as cytokine release syndrome prophylaxis, and then a week later give glofitamab in step-up doses. So we start at 2.5 milligrams, then a week later 10 milligrams, and then a week later 30 milligrams. And then patients receive 30 milligrams intravenously for a fixed duration of 12 cycles. We evaluated 155 patients with diffuse large B-cell lymphoma. 154 received treatment. The vast majority of patients had disease that was either refractory to a prior line of therapy or refractory to the immediate prior line of therapy. And roughly a third of patients had been exposed to CAR T cells before, which is very relevant given that CAR T cells have entered the standard of care for diffuse large B-cell lymphoma. The primary endpoint was complete remission rate, because complete remission is important in this aggressive lymphoma. When we want to achieve durable remissions and the potential for cure, patients need to achieve a complete remission first. So we chose complete remission as our primary endpoint. So the most important finding of this trial was a complete remission rate of 39.4% in this population of patients who had highly refractory and treatment-resistant disease. So these patients had all had 2 prior lines of therapy, and we know that the prognosis in that group is very poor. And glofitamab was able to induce this high complete remission rate, 39.4%, and that's pretty remarkable that it can achieve that through T-cell activation in a chemo-refractory and CAR T-cell refractory population. The other important finding was that in that subset of patients who'd been exposed to CAR T-cells before, the complete remission rate was comparable. And when we looked at subgroups, looked at high LDH, high disease burden, other things that might predict refractoriness to standard therapies, we could see no difference in the subgroup analyses, except that patients who had relapsed disease as opposed to refractory disease had a complete remission rate of around 70%, although, as mentioned, that group represented a minority of the recruited patient population. Another important finding was that the complete remissions were sustained. So roughly 80% of patients had retained their complete remission rate at the data cutoff. In the analysis presented in the New England Journal, the median follow-up was roughly 12 months, and we know that treatment stops at around 8.4 months. So patients who had achieved a complete remission and then stopped treatment were retaining that complete remission, which is early evidence that a fixed course bispecific antibody could be sufficient to induce durable complete remissions for this particular histological subtype. So we know that what the toxicities are from T-cell redirecting treatments. From our experience with CAR T-cells, we know that activation of CD3 positive T-cells leads to cytokine release syndrome. And indeed, cytokine release syndrome was the most common side effect with glofitamab, but this was predominantly low grade, so grade 1 or grade 2. And what's important with glofitamab, and where glofitamab stands out, is that the timing of the cytokine release syndrome is very predictable. It comes on around 10 hours after the first infusion, and it's most common after the first infusion. It's a first dose effect. It's predominantly grade 1 or grade 2, and in the second and subsequent doses, it's much less common. We learned from this clinical trial that it appears that if you use dexamethasone as a pre-medication, that in fact, anything greater than grade 1 CRS is very uncommon from the second dose of treatment onwards, which means that physicians can plan how to manage their patients, and it means that we can develop Glofitamab essentially as an outpatient treatment, which I think is very important. So that was the first finding. Cytokine release syndrome was as expected, but it was manageable for the most part with typical interventions for cytokine release syndrome. The other really important finding is that T-cell activating treatments cause neurologic toxicity. So we've seen that with blinatumomab, which is a T-cell activating bispecific T-cell engager that we've used in acute lymphoblastic leukemia, and we see neurologic toxicity with that treatment. And we also see neurologic toxicity with CAR T-cells. What was interesting with Glofitamab was that neurologic toxicity was vanishingly rare. And in fact, across the whole study, only 3% of patients discontinued treatment due to a toxicity that was attributed to Glofitamab on the trial. So overall, a very well-tolerated treatment, which is exciting for patients who, up to the point of their second relapse, may have had to undergo fairly intensive treatments. So this is a very well-tolerated treatment. I think that was an important finding from the trial as we presented in the New England Journal.